All right. Another thing to remember is, our heart is innervated with a ton of nerves. So obviously, as you can imagine, autonomic tone can affect conduction, refractory speed, and automaticity, right? So sympathetic tone obviously will increase conduction velocity, decrease your refractory period, and increase automaticity. Makes sense, right? And then increased parasympathetic tone will decrease conduction velocity, increase refractory period, and decrease automaticity, which again makes sense, right? The one thing to remember is that the AV node, compared to all parts of the heart, is actually richly supplied with parasympathetic fibers. So therefore, when you use the vagal maneuver on the patient, it will work because you increase the vagal tone, right? All right, so now let's get, huh? Yeah, we have sympathetic too, but when you look at, the comparison of fibers, there's more tension. I was told that I realized it's a red.
Okay, so, yeah. So it goes back to that.
Yep. Hence it increases the conduction velocity through the AV node. So it does have sympathetic. Thank you, Dr. Secretary. All right, so now we're kind of getting into the nitty-gritty of the EP study. So what are we actually doing in the EP lab, okay? So the EP study at its core does two main things, okay? One is that it records the electrical system of the heart. Obviously, you have all these catheters in, and they have all these electrodes, cathode and anodes, and what they do is it records the heart's electrical system. And the second thing we do is we pace the heart at different areas and see what happens, right? So the catheters that we use, obviously, we have a catheter in the high right atrium. We have a catheter located in the His bundle. Catheter in the coronary sinus, which I want to allude to, is that it allows, when you do the coronary sinus, what things are we actually assessing is that we're looking at the left atrium and the left ventricle. As you can imagine, it goes to the coronary sinus. The things to remember when you look at these intracardiac tracings is that you'll see CS910 and CS12. So remember that CS12 is actually the distal part, is the tip of the catheter, and CS910 is actually like the more proximal part of the catheter, and that is the proximal part of the closest to the AV node. This is farthest from the AV node. You guys listening? Okay. And then obviously you have the RV lead, which can also sense and pace. Okay. So essentially, as you can see, just like an EKG, we do EKG on the chest. This is kind of like a nice EKG intracardiac, because if you know your basic cardiac anatomy, which I kind of went over, and you know all the positions of the catheters, you can actually map almost everything in the heart, except the right side. Does that make sense? So this is why an EP study is actually really interesting, okay? And so this is kind of a nice pictorial exam of all the different types of catheters, okay? So obviously, what's this one? Hypotheses atrium. How about this one going down here, going into the coronary sinus? Yeah. Okay, how about this one here going down here? RV. And then this guy, this, and this is your ablation catheter.
So where would CS1 be?
So CS1 would be here, and then CS910 would be here. Does that make sense? So proximal, distal, okay? And this is important because this is going to help, if you understand these concepts, it's going to help you map what's happening in terms of electrical conduction in the heart, okay? And lo and behold, this catheter is actually pointing towards the flow pathway. All right, and then this is kind of like a nice tutorial here. This is the EKG. This is the regular EKG that we normally see. This is the high right atrium, so this tells you the signal. And the one thing to remember about the EP study is that we're only looking at depolarization. All these catheters are filtering out repolarization, only looking at depolarization. So all this is depolarization aspect of the what's happening in the heart. So high right atrium, this is the His atrial, His signal, ventricle. This is the proximal CS, and this is distal CS. Okay, so you see that the conduction is going down from proximal to distal. It's very subtle, but that's the conduction. And then lastly, you see the RV. Make sense? All right. So now what hits is some terminology, nothing too difficult. All things you've heard before. Okay. Cycle length. I don't need to say anymore. But the thing to remember is that the shorter the cycle length, the faster the heart rate, right? Coupling interval. So this is the interesting thing. So coupling interval is that sometimes you can pace. So you're pacing at, say, 300 milliseconds, right? The coupling interval is the interval when you pace a little earlier. So if you pace at 300 milliseconds and you bring in another pace beat, say at 150 milliseconds, the 150 milliseconds, that's the coupling interval. When you bring in a premature impulse, the time frame of when you bring it in, that's the coupling interval. I'll show you a picture in a little bit. Okay? Incremental pacing. This is something that we also do, which is basically you're pacing at a specific cycle length. So like 600, 8 beats at a time. Okay? And then program stimulation. So this is what we do to help, either terminate or activate different types of tachyarrhythmias. Is that either you can pace at specific coupling intervals, or you can provide a train of pacing. So you do incremental pacing, and then you bring in another premature impulse, okay? And we do that in the EP lab to see if we can induce arrhythmia, all right? So this is kind of a nice picture. So as you can see here, so each cycle length will be 400 milliseconds, which is about 150, right? This is the RV apex. This shows incremental pacing. In this case, it's at 400 milliseconds, so it's all the same, okay? And it stops. Here, this is program stimulation. This is kind of an example of it, where you incrementally pace, in this case at 600, and then you bring in a premature impulse at 250 milliseconds. And so in this case, the drivetrain is at 600, and the coupling interval is what? 250. Does that make sense? And so basically what you see in the EP lab is you keep a specific drivetrain, and you keep bringing in your coupling interval, and you see what happens. Because remember with the AV node, right? If I bring in the coupling interval, what's going to happen with my conduction? It's going to slow down because of decremental conduction, okay? Okay, and so essentially, this is basically the different intervals. The one thing to kind of remember, which we can talk about a little bit, is, the PR interval is made up of the A, H, and V. And what we'll find is that the A-H interval will actually vary, as you can imagine, as we change our coupling interval. Did I lose anybody, or we're all on the same page? Okay, good. All right. If anything, hopefully you guys will come off with some basic knowledge, okay? Another key concept, we're almost there, concentric activation. So concentric activation basically goes through normal conduction. So when you see normal conduction, that's concentric activation. Eccentric activation, when you pace, and the conduction goes through something that you do not expect, which is, say, an accessory pathway, okay? And that's called eccentric activation, okay? So a quick example. So I just want to kind of emphasize just the key points. With concentric activation, obviously when you activate, in this case, we're pacing in the RV, okay? When you pace in the RV, remember, this is kind of different from what you normally think. You go from RV to AV node to A. Does that make sense? So if you pace in the RV, this is the V, and this is the A, okay? So what you would expect is you're pacing, say, in the RV apex, the CS proximal will get activated first, right? So that's the most proximal. As you can imagine, too, the atria closest to the AV node will also get activated, and it's going down this way. This is normal. And that's concentric activation, okay? I don't want to belabor it because we won't see it most of the time. Check this out. So when you pace, this pacing is much faster. Remember, we're going at 500. You bring in the RV pacing, coupling interval, or the incremental pacing time is shorter. Remember, we're going from V to AV, right? To A. So as you bring it in, the VA interval gets longer compared to the last. Remember, the V and the A were very close. See? Here, the VA is longer, and guess what's interesting? The distal catheter gets activated first instead of the proximal catheter. Okay? So so that's eccentric activation. So when you see that, you're going to have to be thinking, this doesn't look right, there must be something going on. Okay?
It was.
Yep.
Not the exact encryption.
Okay?
Almost the exact encryption.
But do you see? Okay? So, yeah, and it was actually a accessory pathway, okay, in the entraining exam. Okay, so basic EP protocol. Okay, this is what we generally do, but each each attending will do it differently. Okay, some cases will do like RV pacing first, some people like to do HO pacing first, but, you know, it doesn't matter. They all do the same thing. So first you start with HO pacing, basically look at the SA node, automaticity, and conduction, which is basically overdrive pace, the SA node, and you see what happens. You stop, and you see what happens. AV node conduction, we kind of saw that earlier, and you look at the His-Purkinje conduction. And then ventricular pacing, like the last eccentric activation, you see what happens. You see if there's any retrograde conduction, okay? And then you can induce ventricular arrhythmias by programmed stimulation, okay? And you can do drug testing, you know, isopril and all that jazz, okay? And then you see what happens, okay? All right, now we're getting kind of more of the good stuff. I won't belabor too much because Dr. Sutherland already mentioned it. But when we talk about SVT, the three kind of big players are AV and RT, which kind of makes up 60% of all the SVTs. AVRT is 30%. HO reentry is the remaining, so it would be like 10%. Okay, and obviously the AVRT is an AV node. This is a macro reentrant, which requires a specific pathway, whereas this is only in the HREF. Got it? All right. So the thing is, there's a common theme about reentry. The common theme is that you have to have a dual AV node or dual pathway, meaning that you have two types of tissues that have different electrophysiological properties, okay? Otherwise, reentry doesn't really make sense. So just looking at A, so obviously, you know, I think you guys already know this, but there's a slow pathway, and a slow pathway has a short refractory period, okay? And then you have a fast pathway with a long refractory period. So this is, you kind of have to believe me on this one. Believe on faith that this is the case, okay? And so basically, arrhythmias can happen when, when you actually provide a premature impulse that comes in when one of the pathways is refractory and it goes down the other pathway. And okay, you guys follow me? So we have premature impulse and it comes in here and the fast pathway is refractory, so nothing goes down. Remember, the fast pathway has a long refractory period, right? The slow pathway, then because it can't go down the fast pathway, it goes down the slow pathway, okay? And it goes down super, super slow. And the fast pathway eventually will recover. So by the time it recovers, the slow pathway will go down the ventricle, but also can go up because it's now ready to, it's already recovered. And when it goes up, it can cause an SVT. Okay, this is a common thing, so remember this, okay? And you can see here, look at the difference. Look at the PR interval, right? Short, long. So you can imagine the PA interval, because of the premature impulse, comes in early, so that, and it goes down the slow pathway. Okay, common theme, just remember that, okay? You got that? Okay, AVNRT, same deal, right? So you got the AV node, you got the accessory pathway, both are different tissues, right? This one has detrimental conduction, this one does not. So in order for this to happen, this rhythm to happen, you have to have a premature impulse that comes in at the right time where this is refractory. So nothing goes down the accessory pathway, but it can go down the AV node, okay? But because nothing has happened here, it's refractory, when it goes down, it can go back up. Okay, and it creates a macro reentry circuit. Okay? One question I get, people ask, well, these medical students ask me, why don't you always have AV and RT? Well, the thing is that this guy also gets activated most of the time. You may, either you see it, which is non-concealed, accessory pathway, but in some cases it can be concealed. Okay, and you may not see it. All right, make sense? So it's kind of the key concept we already talked about. You have to have two pathways with two different electrophysiologic properties, and they have different conduction velocities and refractory periods. And this is AVRT, we talked about that. And then the AVRT, you have AV node accessory pathway. Okay? And the EP study can help you differentiate between these different types of arrhythmias. All right. All right, now to the good stuff. Okay, so we all on the same page, you guys understand? So when you're going to be in EP lab with Dr. Sakaguchi and you see all these tracing, it's like, I got this, all right? So, all right, so So basically, I'm just gonna go through the first one, okay, just to kind of let you guys do it, but I think for time's sake, I may have to go through all of them. But, okay, so obviously, this is the screen that you'll normally see in the EP lab. This is your EKG, high right atrial catheter, your HIT, you have your CS, and your RV. In this case, we're not doing anything, we're just kind of, all the catheters are in the heart, and we're essentially seeing what's happening, right? So basically, if you look at here, atria, right, gets activated, you sense an atria, okay? Atria, so in the HIT, the prox HIT gets activated first with AA, and then obviously in the coronary sinus, the prox gets activated first, and you see that little nice little slope down here, okay? And then you get on the AV node, this is the HIT, and this is the V, okay? I just kind of do that. CS prox, big distal, and that's normal, right? You saw that earlier. AH, because it's going down into the AV node, and you have V, okay? As you can see, I don't want to belabor too much, but the V tends to happen a little bit earlier in the distal, and that's actually normal, okay? Because obviously you have the Purkinje fibers that kind of go around, so the distal part of the LV also gets activated at the same time. So this is the same picture. Nothing has changed. I'm just showing you the AH interval, okay? AHV, and then this is the AH interval, and then the HV interval, okay?
Dr. G, the V for the HD is the earliest sharp deflection that you go for the
It's the, you measure the HV interval by the earliest critical deflection any place.
Okay.
So the AH interval, trying to estimate AV node convection. And this catheter is sitting right over this atrial activation of the atrium right before you enter the AV node. Now you're in the AV node, and as you exit the AV node, you grab your hips. The hips bundle conducts very fast. So it's a pretty, whereas the AV node conducts very slowly. So it's a pretty good estimate of AV node conduction. HV interval, you're trying to estimate entry into the history of the H. Exit. Who knows? It can be anywhere. So as a surrogate for knowing where an exit, we take the earliest depolarization anywhere. That's also why we have a pathway.
We may be able to see that today, we may not. Okay, so,
We'll get there.
all right. Okay, so this is program stimulation, drivetrain 600, coupling interval 420. All right, so what I want to show you here is that, so you see this, you see the A to H interval here, it's not that long. But then when you bring in the coupling, when you bring in the early premature beat, look at the AH interval. They're lengthened. They use your little thing like a sensitive, and you don't believe me. So you see the AH interval here? Okay, this is a drivetrain of 600, right? When we bring in the 420, look at the AH interval. Longer, right? And that's normal, because that's the AV node. You see decremental conduction. All right. So now, so as you can see, like what happens in the EP lab is that you do these program stimulation. You start at like 600, or 600, 580, 570. I'm just showing you the highlights. Okay.
By the way, Matt, you know this is
All right.
Thank you, Tabuchi. I was not updating. Okay, so AH interval, I wanted to show you that it's different. It's longer, right? Because you're bringing it in, and that's what you expect because of decremental conduction in AV node. All right. So AH time gets longer. Control interval. Decremental concussion. Okay, this is repetition is the mother of all learning. I heard this 5 times. Okay. All right. So guess what happens? I go from 600 to 410. Look at the interval. It went from 198 to 365. But when I went down from 420 to 410, there's a big increase in the AH interval, which is like, remember, like the you're going down, what path are we going down now? Low pathway, right? So essentially, we brought in a premature impulse that was refractory down the fast pathway, it goes down the slow pathway, and you actually see the prolongation of the AH interval. Okay? So now we're like slowly going down the slow pathway, the fast pathway is refractory. Okay? And this is called the AH jump. So have you ever heard this term? This is what's happening, okay? So you jump, right? From the fast to slow. The definition from Dr. Bendit is that if you have an interval increase of greater than, I should have had this definition. But if you have an AH interval that is greater than 50 milliseconds, when you decrease the coupling interval by 10 to 20, that's the definition of AH jump. Okay? So in AH result went from 198 to 265. AV and RT starts. Okay, so I'm just going to go over for you, and I'll show you how cool it is, okay? All right, AHV. Remember, now we're going to go up the fast pathway, right? So see the fast pathway going up, and you see the A. Does that make sense? Remember that picture I showed you? The little circular thing? So it's going down, and then it goes up the fast pathway. And remember, the VA time is super short. Does that make sense? And then it goes on the V. Okay, and then it goes on slow pathway. Okay, and then H, V, up the fast pathway, down the slow pathway. Okay, do you see that? Yes or no? Okay, so basically we just activated in the EP lab AVNRT, just by doing program stimulation.
Is there anything else that can cause essentially simultaneous activation of other than AVRT?
Yeah.
Okay. Okay, the fast junctional attack.
Yeah.
What are some of the clues that can differentiate that? Is there anything in terms of observing it in this situation?
In this situation, no. If it's
Okay.
Maneuver is a totally different topic. I have some maneuvers to show you, but, I think our time is limited, so, if I have another opportunity, okay? And then fast pathway, okay? And then this is just the picture I want to show you what happened, okay? So this is what happened. So we used my diagnosis in the EP study. That patient has AVRT. Obviously, you'll do some maneuvers to make sure it's not like a junctional tachycardia and so on and so forth, but that's not the topic for today. Okay, so the EKG strip. So remember what Matt mentioned, or I think Surya mentioned, that was like a like a retrograde P wave. The EKG, especially in the V2, you get the pseudo S prime, and then you get pseudo R primes in V1. And that just shows you, like, you wouldn't see it in a normal EKG. All right, and then detect cardiac cycle length, which is how fast it's going, fast pathway, slow pathway, fast pathway. Okay, so basically, just remember, so this is the B, and it goes up to the A, down the AV node. Okay, obviously it's also going down the A and the B here, but I just wanted to show you just in the hip and the HRI to kind of demonstrate the concept.
And you're still concentric in your CSV.
Yep, and it's still concentric, as Jeremy mentioned, it's going down from the prox to the distal. Okay? Okay. So this is, so basically, I just want you to see just some anatomy. This is a triangle of Koch. And basically, these are all the same 4 pictures. The only thing different is that you see catheters and more diagrams to demonstrate what's happening. So basically, this is the coronary sinus. This is the slow pathway. This is the fast pathway. And the triangle of Koch is this triangle here. Okay? So this picture is basically the fluoroscopic picture with all the catheters in, the ablation catheter, which is on the slow pathway, and then you have the hip and the coronary sinus, okay? And this picture is the same picture, similar to this, but with catheters, and this is with everything, okay? And so essentially, this is how you ablate the AVNRT, because you put a catheter in the slow pathway, because you made that diagnosis, and then you ablate it. This is just a cardinal picture, nice picture of CT showing where the flow pathway is, where this little guy here. These are just cool pictures, but we can use Cardo to help identify the location of the flow pathway, and we can ablate it. Basically, Cardo, is when you take a CT of the heart and you do 3D mapping, and that 3D mapping is correlated with the catheter. So you can actually
You don't have to do CT. So,
you have to,
Basically, these are, there are various systems in which computer can locate the catheter, and you can take that catheter and trace the entire geometry of the chamber, store it, and then you take that catheter and put it in a different location, and it tells when that particular site activates through the atrium, and by color coding where the first part of the firing, and you can use it to locate and put it on a hit on it.
so you get to be very specific in terms of what you're doing, so you don't make any mistakes. You don't want to burn fast, right?
Cardo has a triangular EKG. For those of you rotating through the EP lab as a general fellow, I think some of the best time, the most you can learn about stuff, is helping them get set up for the patient, because they go through setting up all the Cardo, at least they're using Cardo, which is Python cluster, but they set all these things up, they put all the things in the computer. You can kind of get an understanding for what they're doing from just the basic mechanistic point. Otherwise, you start throwing colors and picking up on the screen, and you're not going to understand what they're looking at. But if you go through and do the whole setup, you actually learn a lot from the text and what's going on.
All right, so we bladed it, he's feeling better, he gets followed up, he hasn't had any palpitations for the last 6 months. Okay, so we actually cured his palpitations in the EP lab. All right, so 456, I have another case, but I don't know, do you guys want to go through it? Or
Show the electrogram.
Electrogram?
Show the electrogram.
I have someone nodding their head, so.
What's that?
You want to do it?
Yeah, just show the electrogram.
All right.
Just skip everything. Electrogram.
So this EKG, for this patient, is given adenosine and a growth, okay? But, I don't know if you want to take a look, see anything interesting? So, kind of similar, maybe a P wave.
RP looks longer though.
Maybe a P wave right there.
The problem here is, which twiddle is a P wave?
Right, yeah.
Okay, so could there be, could there not be? Okay. All right, this is the EKG after. Gonna see. All right.
I have to go back to
All right. Yeah.
Is there just any creative type thing?
No, I don't know. I doubt it. Yeah, I'm sure.
All right, so we don't know, maybe.
Not obvious.
Okay, all right, so maybe another AV and RT, okay, so, all right, so now this is the baseline intracardiac, okay? A, H, B, okay, so you guys see the pattern here? Okay, all right, and so now we're pasting in the A to do the AV and RT, now we're pasting in the RV. So R pacing, and then this little thing here, that's the signal for the V. This is the signal for the A, and it's going from the prox to the distal, okay? At 500 milliseconds, so this is what we're pacing at. Okay. All right, so now I'm pacing out 460 incremental pacing. Do you see anything different? Eccentric, right? So V, you see, we're pacing earlier, the V to A is a little bit longer, right? H and A. You see, it's not from prox to distal anymore, right? It's actually starting somewhere around 5, 6. Okay? Eccentric activation, atrial activation occurs in the atrial occurs in the CS before the hip. You see that the hip A occurs after the CS. Does that make sense? So that's kind of odd, right? That means it didn't really go through the AV node. All right? And then the A is last, okay? Which is not what happened before. Okay? Because this happens after the hip. See the difference? Before. Okay? All right, so B, H, A. So eccentric activation. Okay? And so now, now we'll try to see if we can activate the tachycardia. So now we do activate at 350 for B, and it goes up the accessory pathway, which is the eccentric activation, right? You guys see that? B, okay, and then H, and H. And the accessory pathway, accessory pathway, it goes up to the A, okay? It goes down the AV node to the B, right? It goes accessory pathway, up to the A, down to the AV node, okay? And the same. You guys see that pattern? Yes or no? Okay, so basically, just basically looking at this, which is if you didn't know anything, it would be just a bunch of wiggly lines. You can actually see that the activation of the tachycardia, which in this case is AVRT. Okay? Yeah.
So, accessory pathway. Remember, we did not see a delta wave. So there's a couple possibilities. Some accessory pathways will conduct antegrade only. Pathways will activate retrograde only. Some will activate in both directions. We'll only see delta waves. They activate from top to bottom. Okay? So this is probably what we call a concealed bypass. They can have a bypass track even though you don't see it on. It's also possible that patient has delta wave that conducts top to bottom, but you don't see just because the AV node works fairly well and bypass is just so far away that it's normal condition.
Okay, again, this is program stimulation, and the program stimulation was able to.
Bill, I would draw your angle down to the V first. See how you have it going? Sure. I just think, because how you have it drawn is a little. This is coming earlier, right? So the angle is actually down here. So you can draw, because this happens first. So then it comes back up.
Oh, I see.
Comes down, because when you draw it like that, it makes it look like it's going to the CS, but in actuality, to the V first. So AV,
yep.
AHV, because you're seeing the hip here. So AHV, CS back up to the A. That's what's happening in terms of,
Going down here,
right. But we don't get this in the EP lab. We gotta look here. So
yeah.
A, H, V, back up to the A. You guys all see that? Because when you draw, it's right, but it's a little confusing because you're looks like the V is next early, so the HV interval is shortest, and then you go back up.
Okay. All right. So once you diagnose that patient has AVRT, we do some other maneuvers to kind of make sure we won't go over. But it looks like the earliest activation is around here, right? You guys agree? Okay. So in order to ablate, you have an ablation catheter, and you basically align it so it lines up to where you think which CS node electrode you're at, and probably about here. You see it lines up. Okay. Then you ablate. So as you ablate, it stops, and then you have the normal activation here. Okay. So this, and the patient is actually in tachycardia at the time that you're ablating, right? So again, B goes up the accessory pathway, goes all the way up to A, and then goes down the AV node to what Matt mentioned before. It goes up the down to the V, and then before it can actually go up the accessory pathway, it's ablated. And so tachycardia starts, and then you have the regular activation.
So this is very cool. The last thing you see is a V. Remember, you're burning that accessory pathway. Essentially running the pathway, it can't get to the A and it ends.
Cool?
That's all.
All right. So 2 cases, EP has cured 2 patients today.
Quick break, and then we'll present our cases.
Great job. You learned a lot.
Good job, Bill. You were the first general counsel who's not going into EP to tackle an inter-party action.
Oh, yeah.
They still are, you got
Oh, yeah, yeah. So.
No, that's okay. It takes 2 seconds. We're good. See you. Right here. We're good.
you good with that? So here you're pacing the ventricle. You're on your early phase, in the coronary signals. And now you're in tachycardia, you're in phase. You're pacing the ventricle, you're going through the extensive calibration. You're in tachycardia. Look at the VA interval here, compared to the VA interval here. This is very simple.
So let me think about that. Is it because the hit is, well, the Kinsey system is closer to the accessory attachment and the catheter?
Yes. And on top of that, I think it probably means you've got a slant.
Oh.
So look at this here. You're going from right ventricle, then you're activating the left ventricle from mid. Whereas here in tachycardia, you're activating the Kinsey system, so you're activating the left ventricle sort of the same time as the right ventricle. But you still have to explain why the time from A to let's see, or something shorter than this one. Right, was trying to go like here.
Oh, yeah. Yeah.
So, it's going up.
When you're in tachycardia, you're acting from here. Now you got
You want to do EP, right?
What? I want to do
Are you set? Okay, so, how long will your presentation? Wow. From the next, it's just 3. Yeah, quite nice. Very well. So they give me the allocated time of 8 to 10 minutes. So what are the questions that you think you one? They're going to ask you why there's a higher what is the atrium of the third scoring system? They all the same, but they add
All right, guys, can you sit down?
Oh, yeah, thanks.
The ASIC lab is up and running.
You love it, don't you? I love it. Yeah. Some of your findings,
Well, I'm not in the cath lab this week because we're down there, and I was just back Sunday morning.
yeah, that's a good sign.
Yeah, it's a lot of fun.
You really enjoy it.
Yeah, I mean, the system that we built is really made it a process.
It was expensive.
Oh, yeah.
So, you're choosing this and, that's Bob, what you start referring to?
They're just rolling, starting to pick up.
I think we'll go ahead and get started in a few minutes. I think Chadi just stepped down. This is a tradition that, why don't we shut the door right here? So this is a tradition at most academic medical centers. They always present their posters and their oral presentations before the AHA and or the it's been going on for many years. I remember the first time I did it, it was a different amount of faculty did in the front row. And where I was, Dr. John Ross was the chief of cardiology, and he was a very formidable figure. And I remember getting up and I had to present an abstract on how to diagnose CW by echo. We had a lot of criticism. The main thing he said to me, I'll never forget it, I learned a lot. He said, do you really believe these data? You don't show very much animation. You know, when you present about 50% of it is science and 50% of it is actually excitement, and indicating to the audience that indeed this is really important to you. That do it again, or I had to do the whole thing over again, and it went much better, and it was a good lesson. So I think that's one of the reasons why we do this. It's also to kind of anticipate the questions that might come up. The very first time I presented was in New York City. It was an echo paper again. The audience was packed. And the first question was from someone from Japan, and I could barely understand the question at all. I had no idea what he actually said. It was embarrassing. And the moderator was very kind. A guy named Dr. Harvey Feigenbaum, some of you might know the name. He had the person repeat the question. So anyway, it's a time-honored process. It's an important process. My advice is to go slow, enunciate your words, make sure that we can clearly hear your message, be excited about your message, be on time. It's supposed to be 10 minutes or more. And then we'll open it up for some questions. So we just have 3. I think it's better to concentrate actually on a few than to try to get to 20. I don't know how many abstracts are actually being presented, but I know it's quite a few. All right, so our first speaker this afternoon is Chadi. Everybody knows Chadi. And he's going to be talking on the CHA DS-VASc score and the risk of ischemic stroke and atrial fibrillation. And his mentor is Untitled Chapter. Chadi, why don't you take it away?
Thank you so much for inviting me to the talk. And so as the conference, this is a good practice for me, so I will save all the questions till the end. If you have any questions, please save it, and we'll have enough time at the end. So the title of our work is the CHA DS-VASc score and the risk of ischemic stroke by atrial fibrillation using the atherosclerosis risk of communities study, the ERIC study. And this is the list of the author, and the mentorship is Dr. Lynchen. To give you a little bit background of the study, CHA DS-VASc has been widely used clinically as a score risk to risk classify the risk of stroke in patients with AFib. There's some studies showed that some signals suggesting, especially in patients with MI and heart failure, that the CHA DS-VASc score can be used to stratify the risk of stroke in patients with no AFib. And anticoagulation, furthermore, may be indicated in patients with high CHA DS-VASc score, even in the absence of atrial fibrillation. And this is, the author came to conclude that probably the vascular risk factors and not the AFib itself that drives the risk of stroke in this cohort. Going through the literature, this is the three major studies that done regarding that. The first one was published in 2014, where they looked into the risk of stroke and CHA DS-VASc strata. And as you see here, there is an increase in risk of stroke in each increase in the CHA DS-VASc score. And this was statistically significant. And this is especially in patients after acute coronary syndrome. Another group did study and published in March 2015, and they used that, they concluded that the CHA DS-VASc also could conclude or could correlate with the risk of stroke in patients with no atrial fibrillation after open heart surgery, either valve or CABG. And lastly, this is published just 2 months ago by Gregory Lipp. Everybody heard his name today multiple times, in JAMA. And in this study, they looked into the CHA DS-VASc and risk of stroke in patients with no history of AFib, but with history of heart failure. So as you see here in this diagram, there is an increased absolute risk of stroke in patients with and without AFib. However, it's unknown at this point whether CHA DS-VASc score correlates with the risk of stroke in community dweller, and especially the one who doesn't have history of AFib. So that will take us to the aim of our study. We have two aims. Number one is to investigate whether the CHA DS-VASc score could predict ischemic strokes in community dwellers without history of AFib. And the second aim is CHA DS-VASc score could be used to guide anticoagulation therapy to prevent stroke in community dwellers without, again, history of AFib. We hypothesized two things. Number one, the CHA DS-VASc is associated with ischemic stroke in community dwellers without history of AFib, again, and the CHA DS-VASc can be used to guide anticoagulation therapy in a general population without AFib. In order to study these two questions of two hypotheses, we thought probably ERIC database would be the good database to use because it's multi-center, prospective, biracial cohort study and enrolled more than 15,000 participants. And it has in 4 different communities, and they follow them serially every 5 years, with the last follow-up was in 2013, but they have also a yearly follow-up. Our inclusion for this study were every participant who were available or attended visit 4. And our exclusion criteria were if the patient has or participant has an AFib or has a stroke at visit 4, they were excluded. If they have any missing CHA DS-VASc variables, everybody are familiar with those, and race other than white or black. In ERIC study, the diagnosis ascertainment is done by using, especially in AFib, the AFib diagnosis was ascertained by using ICD codes and ECG performed during visits and also after patient discharge from the hospital. So it's very strongly ascertained. And the stroke was ascertained also using ICD codes, hospital discharge summaries, and also visit summary. And all these strokes has been adjudicated by a separate physician by going through MRI and CTs. So it's a very solid and reliable database to use to study these two important hypotheses. So our statistical analyses, number one, time to prevent and to event analysis was used to study the association between CHA DS-VASc score and risk of stroke. And follow-up time was used from the time of inclusion, from baseline to occurrence if either stroke, death, loss to follow-up, or end of follow-up, whichever happened first, and also patients who were initiated on anticoagulation during the follow-up period were censored. We divided our cohort to 5 groups based on the CHA DS-VASc 0, 1, 2, 3, and 4 and more. And we calculated incidence rate difference and incidence rate ratio in both AFib and non-AFib in each CHA DS-VASc category. And we did also competing risk analysis to accommodate risk of death. And finally, we did the C-statistics. We spoke about it today to study the discriminatory property of the CHA DS-VASc in AFib and non-AFib population. So let's go to the results and find out what we found here. Let's go through the inclusion or study diagram. All participants who were at visit 4 were close to 12,000 participants. Almost 1,000 patients or participants were excluded because they did not meet the inclusion criteria. They met the exclusion criteria. That left us with more than 10,000 participants, of which more than 1,300 developed AFib during the course of follow-up. What we did, we matched each AFib individual with 3 controls. So that left us with more than 1,300 AFib patients and more than 3,700 of controls. This is a table that shows you the characteristics of the patient with and without, based on AFib status. On the right side, you see the AFib, and the middle column is the patient with no AFib. We try to match these cohorts based on age, plus minus 5 years, calendar year, race, and gender. As much as we can, also we applied the matching for the CHA DS-VASc score. This is one of the, I would like to bring your attention to this table. This is one of the, kind of summarize most of the findings here, that talks about the stroke incidence in participants with and without AFib based on CHA DS-VASc score. So starting with the patient with the cohort who has no AFib. As you notice here, the crude incidence rate goes from 0.4 all the way to 6.3. So there's an increased incidence of stroke on patients with no AFib. But however, as you can see here, this is a very low incidence rate because this is based on per 1,000 persons. So this is translated into 0.6%. When we compare that to the AFib cohort, it starts at 12.0 and goes all the way to 72.1. So even patients or participants with 0 CHA DS-VASc score, by adding AFib, their stroke rate is really high. To do the incidence rate ratio and incidence rate difference, we have, it also has the same signal from 11.6 all the way to 65.8. So there's an increase similar to what we have seen in the past studies, increased signal or increased risk of stroke as the CHA DS-VASc goes up. Then we did to accommodate the competing risk of death, we calculated the absolute risk using the Johansen study method, and also for the relative risk, we did a different calculation. So this is translated into the absolute risk of stroke at 1 year follow-up for a patient with AFib and without AFib. The open circle is the normal population without AFib, and the dark circles are the patient with AFib. And this is, again, the same thing we see in the relative risk. When we did the follow-up over the course of 5 years, we have the same signal. There is an increased risk of stroke in patients with AFib and also in patients without AFib, but the incidence rate of stroke is really low in patients without AFib. Finally, we did also follow up over a course of 10 years, and the signal still showing the same, increased risk of stroke, increased incidence of stroke. The C-statistics was kind of modest, 0.64 to 0.60 in patients with and without AFib. As Dr. Madeleine K described today, it's kind of in the modest, but this is kind of considered this is considered a very good predictor in general. So what is the key findings of our study? Number one, CHA DS-VASc score associated with increased risk of stroke in patients without AFib. And the absolute risk of stroke is really low, even with high CHA DS-VASc score in people without AFib, as we can see 4 and plus CHA DS-VASc. However, in patients without AFib and CHA DS-VASc of 0, the risk of stroke is really high. There's limitation to our study. First of all, is that the most is the misclassification of AFib. This is subject to error. Probably we missed few participants who had true AFib, and probably people have been mislabeled as AFib, but they have different rhythm. In conclusion here, I would like to have two take-home messages. Number one is CHA DS-VASc score can only be used to guide anticoagulation therapy in community dweller without AFib, cannot be used. And second, and this is kind of a hypothesis generating point, higher stroke risk in people with AFib with no other risk factors suggests there is something specific about AFib per se, and not the vascular factor as suggested by previous study that increase the risk of stroke. I would like to acknowledge the grants that supported this project, and thank you, and open for questions.
Questions for Chadi?
I think it was a great presentation, but I would say it's between, and just to kind of see in the slide, with depending on the size of the road, maybe parts of people in the state, the colors like white, green, black on there, they're very hard to see. So, it's like it's a really simple, black and white, and people and pretty much for any of the people that are being credited, each font larger, so if they're going to be listened to, they're going to be listened to.
Thank you. Good point.
Some of the no AFib patients, participants may have also had undetected AFib with brain monitoring. I doubt it, right?
Yeah.
So those numbers might, the difference might be even greater.
Exactly. We might be not capturing or even capture. People has been in intermittent or paroxysmal.
How does the non-AFib CHA DS-VASc event rate correlate with other studies that have looked at similar questions in the European model? That, to me, that would be something interesting to potentially show if you could get if you could show that data, and where your data lined up.
Yeah, very good question, Matt. This is the incidence rate in general of AFib in that cohort, in the ERIC cohort, has been 12.7%, which is close to what has been published before. But surprisingly, the rate of stroke is a little bit higher, especially with the lower CHA DS-VASc in our study. Again, it's either because of including a longer follow-up period or because we are following people for almost 10 years that we have some kind of inflation in the incidence rate. But I tried to compare it before, and it's a little bit higher than compared to other studies.
What is the central core message?
Patients with no AFib, and even very vasculopathic, patient who has CABG, peripheral vascular disease, they don't still qualify or don't, the anticoagulation is not justified in this cohort because the incidence rate of stroke is really low.
I think that needs to be articulated slowly and carefully. Maybe think about the way you want to say that, but when you finish at the end of the talk, there should be a central message or a core message that people take away. And I think it's useful to slow down when you come to that and look at them in the eye and sort of say, the central message is, and then slowly articulate it without any mistake.
Yeah.
Other questions or questions about the data?
Very interesting. But how does this find
The aim, yeah, it's we kind of first of all we put the background, what has been known already, and then we started to study the aim of our study, and then I just put a slide for the hypotheses, and then we kind of, as you see here, we rejected the hypotheses for one and accepted the other. But I agree with you, there might be some redundancy in these two. Yeah.
Then what is the central core message here?
So it's actually in the conclusion slide, right?
Yeah.
Which is, although CHA DS-VASc score giving stroke risk in people without AFib in the general population, the absolute risk of people with stroke is very, very low. Even in those with the highest CHA DS-VASc score, such that this result cannot be used, you know, to recommend quantitative.
That's the message. You hear that? Anything else before Ryan takes the podium?
I think to ask, but even if there was an increased risk, how would you know the anticoagulation is the correct treatment anyway? You're saying it as though there's a thromboembolic risk versus an atherosclerotic risk. So predicting risk is different than knowing the treatment is effective, right? Unless you have data, be careful you don't apply that somehow antithrombotic agents will make a difference. You don't know that.
It's been proposed by different studies. I mean, we're just trying to show that it's probably not the right.
And then it might, I think Alan's point is well taken, and this would be between you and Lynn, but sometimes it's helpful when you start to tell the audience why you did the study. I mean, you could say, you could even cite a reference quickly and say, it has been suggested by experts that we ought to consider anticoagulation in this population. Therefore, we decided to study a large cohort, et cetera. Kind of sets the stage a little bit. It's a nice piece of work. Good job.
Take a look, right.
Brian. So Ryan has an interesting title. Half of, presumably all, inflammable